Okay, I'm going to talk through this. I put down in announcements that I added a few slides and I made it available in announcements, and I also put it in your weekly session. Ellen's been trying to teach me how to make it to an PDF format, which I did, but I don't know if that's any benefit in the PDF format. And so when I do the slides, I have some slides that are made from last semester, and I might make some adjustments, and I will let you know about that. I recognize that I talk really fast. I also know that your brain can listen much faster than I can talk, and that's why archiving is done so that you can go back and review. Yes, I am going to mention everything that will be covered on the test, and I wanted you to know that because this information is not in the book. So the first slide has a fish, and what this means is sometimes when people
Do you have lock talk on?
I'm holding it. I'm not quite sure why I'm getting that back feedback. Now I'm not getting it. Anyway, sometimes when people do diagnostic testing, they're fishing for anything and everything. And the problem with fishing is you're not quite sure what's going to come out of the water, and then you're not quite sure what to do with it once you get it out of the water. So the goal in diagnostic testing is to make sure that the test results will help you rule in or rule out a specific disease. Now, many of you are in your initial stage of nurse practitioner role, and you may not be able to do that. But what you do have is most of you have an iPhone or a handheld phone that has either Diagnosaurus on it or Medscape or Hippocrates. And under the diagnosis, it usually tells you what lab tests will help you rule in or rule out that information. And I implore you to use that in front of your patients, in front of your preceptors, so that you learn what tests provide valuable information, what the cost of the test is, how the insurance covers that test, and if you can continue to use that test. First thing we're going to talk about is cancer screening, and I wanted to ask you a question. And when I ask a question, if you just type on the bottom, it's easier. So is cancer preventable? All of you type your answers. Wow, I'm pretty surprised. And what makes you think cancer is preventable?
Well, I think that some cancers can be preventable based on our own health. For instance, I may be less susceptible to lung cancer if I'm not smoking or in contact with secondary smoke.
Less susceptible is not preventable. Go ahead. Give me a response.
Is it me?
Somebody else tell me, is it preventable? Well, my view is that it's not. But what our goal in cancer screening in the United States is to find it early and to treat it in its earliest stages so that the death is less likely. Usually when we talk about somebody is cured for cancer, please note that that means that 5 years from their initial diagnosis, they haven't had a relapse. And once you have one kind of cancer, it increases the chance that you'll have a second type of cancer, because cancer is really a behavior of normal cells. And the behavior is that cells, either due to genetic or what's called the double hit theory, a cell is susceptible and then it interacts with an external stressor or an internal stressor, and it changes its behavior. The two behaviors associated with cancer cells or lack of adhesion and metastasis. Usually, cells want space between themselves and other cells, sort of like you might have felt when you were 13 years old and you thought people in your class had cooties and you wanted distance from those people. So normally cells have distance. But cancer cells, what they do, and this is what a cancer does, it reaches out and it goes through cells. And when it goes through a cell, it destroys a cell. So that's a behavior of a specific type of cell, usually attributed to a cancer type of cell. The other behavior associated with cancer cells is that they metastasize, i.e., they travel. Um, the cell in the lung decides it wants to go see the brain. The cell in the breast decides it wants to go see the bone. The cell in the prostate decides it wants to go see lots of different parts of the body. So the cells metastasize. So those are the two behaviors associated with cancer. Now, when we talk about that type of behavior, the question is, does that behavior go on routinely in the body? And the answer is yes. Your goal, hopefully, in an attacked immune system is that your cell sees a group of cells based on the size and the shape, and then it does something, the immune system, to attack that cell growth so that minimizes the damage produced by that cell. So that's a theory of what cell is, what cancer is. So the question is, can we reduce the interaction in the double hit theory to people who are genetically susceptible from an interaction either internally or externally? Internally would be smoke. External might be exposure to sun or radiation, to decrease the chance or the susceptibility to cancer. That's a theory. And theory is important. There's 4 different levels of theory: describe, explain, predict, and control. And the goal is we'd like to, in healthcare, control who gets cancer and who doesn't get cancer. But we can't do that. We can only predict people who are more likely to get cancer, and then we screen early and decrease deaths from cancer. So when we talk about cancer screening guidelines, and there's plenty, what the contributors tend to be, as Ann addressed, is tobacco, certain dietary factors. Sometimes people believe that meat or the ingredients in some processed foods cause changes in our DNA or RNA, making the cell more susceptible to those behavior in the cells. Sometimes infections, and this can be a gross infection of the body or a specific infection, as in HPV, can cause genital cancer. Exposure to radiation, and this is non-ionizing and ionizing. Lack of physical activity. Nobody's quite sure why sitting on the couch makes you more likely to have cells that behave in that certain way, but they do. Genetics, 5 to 10%, is related to your family, first-degree relatives, and in some cancers, second-degree relatives. It makes you more likely to have that genetic predisposition. Other is obesity, and then environmental pollutions. In order to diagnose cancer, the only way we do that is a biopsy. And hopefully in that biopsy, especially for those of you who will be doing biopsies, if your state allows you to do that, is to get enough of the cells so that the pathologist can read what is the normal cell or the usual cell in that particular environment, and then the unusual cell. And based on the presence and the behavior, they can diagnose cancer and the stage of cancer. So in your cancer screening, how does breast cancer, what is the percentage of females, or what a list on females dying is breast cancer in the top 10? What do you think it is? Feel free to write. Is breast cancer the first reason that women die, the second reason, the third? It's usually about the eighth reason that people die. And so our goal is to find out who is in a high risk category, although only 15% of your breast cancers are in high risk categories. And so the other 85% of the people who get breast cancer have the main reason that they have breast cancer, and that is being a female. The other is colorectal cancer, and the goal is to find that, and that is staged by Duke staging, and that's why we do sigmoidoscopy or colonoscopies or fecal occult blood testing to determine if you have an adenoma or what's the word I'm looking for? A polyp that is likely to change into a tumor, and the goal is to find that early. Lung cancer, there is some evidence now that there is a risk of people who are considered high risk, of people who have over 30 pack years of history of smoking or continue to smoke, who are over the age of 50 might benefit from a CT scan or every year or every 5 years. The cancer screening for prostate, the guidelines that have been issued recently say don't test for prostate cancer unless people reach certain high-risk categories, and that is having a first-degree relative that was below the age of 60 and ethnicity of a black person. That makes them more likely to have an early cancer, but they suggest don't screen, and if your patient requests screening, you have to talk about the benefits and risk, financial and emotional, of a positive diagnosis of cancer, because the treatments for cancer can be as problematic as having cancer, and usually over about 70% of those men who are diagnosed from cancer do not die of cancer. So when we list all the cancer screening, the number one cancer that has increased, and depending on what you read, it's either 400 to 700%, is the types of skin cancers. Can anybody tell me the 3 types of skin cancers? And please feel free to write this in. Basal cell, squamous cell, and melanoma. And where do you normally see melanoma? Do people know? On a female, where do you find melanoma on a young white female? Back of her thighs. Excellent, Joan. Thigh and legs. And men, it's on the back. And why that's important, which is what you'll learn in health assessment and throughout your education, is that you have to look where the normal evidence of cancer is. So prevention and screening of cancer. Some active measures to reduce the risk are vaccinations. We tend to think that the HPV vaccine for males as well as females prior to the advent of sexual activity may reduce the chance of getting, I think there are 6 HPV viruses that are associated with cancer, as well as the hepatitis B virus. Certain meds can increase or decrease your chance of cancer. They've been doing studies on long-term use of aspirin they haven't figured out 42, 81, 162, or 325 milligrams on a daily basis, or how often to reduce the chance of colon cancer. The studies they've done has to do with taking cancer and an NSAID. If both of those help decrease the chance you will have the cancer. Genetic testing, when we talk about genetic testing, that's very expensive. I don't really know what that means unless you're the person who may be at high risk for that in terms of breast, colon. I think Angelina Jolie was tested for BRCA1, and some people talked about what was the actual cost of that, and does insurance cover that. And then prevention of skin cancer is sun avoidance. Not particularly the use of sunscreen, because some literature says that sunscreen after the age of 21 may delay the effects of sun damage to the skin, but it won't delay cancer. Skin cancer is usually from cumulative exposure of skin in the early years, starting as an infant up to age 21. So screening for early detection, you have the lab tests. Some of them have a high sensitivity and specificity, and some have low. And I'll talk about that in a few moments. We talk about imaging, mammogram, bone scan, pap smear, or a DNA smear, and then procedures that screen for cancer. Somebody doesn't have their computer or their phone on mute, by the way. But we do know, which Ann brought up early, is that there is an association, and this is a correlation. People who smoke have an increased chance of dying from cancer as well as heart disease. When you talk about the Framingham risk profile for determining what risk you are in the next either 10 or 20 years for cardiac event, smoking increases your risk by about 6%. So the goal is don't smoke. If you do smoke, quit. If you are a provider, you need to ask, advise, assist on every interaction with your patients. You need to ask them if they smoke, and then when you get in the electronic medical record, you have to validate that, and that's called meaningful use criteria, and you actually get money back for validating that you asked the patient for their smoking status on every interaction. And when you ask about smoking status, you find out how many cigarettes or how many packs times how many years, and that gives you pack years. And you want to know how many pack years and if they quit, when they quit. If somebody has 50 pack years, and when they talk about interactions with increases in cancer, it has to do with 25 and 30 and 50 pack years of smoking. So even if you quit at age 50, but you have a 30 pack year history, then you're in a higher risk for cancer the rest of your life. So it's important to know their pack years and the year they quit. Also, obesity. Once again, I don't know why thinner people may have less predisposition to cancer than the obese, but they do. Now they're talking about why people live longer, and they're saying if they are below 15% their ideal body weight, they may live longer due to less caloric intake. And then some of the research says that people over 75 should probably be 15% over their ideal body weight, because if they get sick, then they have some resource in terms of body fat to deal with it. So I think we're really out on what is plus or minus 15% of your ideal body weight. So what about smoking? We talked about weight, and then the other is walking. Many of us are active, meaning that we probably have less than 2 hours of couch time during the day. But there's a difference of being active and exercising. And in America, we're trying to figure out what's the least amount of exercise that we can engage in to, one, increase the chance we will live longer, and that's past our age. I think it's 70, isn't it 77 for men born in this year and 79 for women? Hasn't changed much in the last 30 years. So we want to know what's the least amount of exercise we can do to be healthy. And there is research going on that. I was reading an article 2 weeks ago, and it talked about people who are diabetic. It seems that if they keep their heart rate up to their 80% for 15 minutes in the afternoon, that it's better than doing it 30 minutes in the morning. So they're still out on what is considered exercise, how often you should do it. Some research or review of the literature indicates that 10 to 15 minutes twice a day is as beneficial as 45 minutes once a day. But the goal is to get the heart rate up and keep it up for 10 to 15 minutes. When we talk about lab testing in terms of differential diagnosis, there is a theory called Ockman's razor. And what the Ockman's razor is when you have two competing theories that make exactly the same prediction, the simpler one is the better. Meaning it's probably the simplest thing when you're trying to evaluate a patient. It's the simplest disease rather than the most bizarre disease that you are confronting. Another approach to Ockman's razor is the KISS approach, and that's keep it simple, student. Another you might see the Ockman's razor when you read, do the review and who has a 2-year-old daughter that has positive, and they're thinking that is pharyngitis. You can't hear me?
We can
you
now.
hear me now?
We can now. You were going in and out, and we couldn't hear you.
Okay. So I'll just thank you. I was reading Joan and Sarah and Ellen. I can say it's due to the storms here in Alabama. So with the Ockman's razor, the horses and the zebras, so you have your 22-year-old walk in your office and you're trying to figure out if they have a pharyngitis or a strep throat or if they have some bizarre tropical disease because they went to Belize for 2 days. And the goal is think the obvious first. Think of a horse. Think pharyngitis. Work on the most probable cause versus the most outlandish cause. So why do we order tests? To determine the diagnosis in symptomatic patients, screen for disease in asymptomatic patients, guiding treatment decisions, monitoring the course of disease, and monitoring adverse reactions to therapy. Please feel free. How many people, how many admissions do you think happen in a hospital per year due to adverse reactions to therapy? Here's a little rule I'll give you. You're rarely wrong to say 30% in the field of healthcare. When they talk about why do people live long, they'll say 30% genetic, 30% to behavior, and 30% to causes I don't know anything about. When they talk about studies and they say what's the when we talk about effective studies and it's called the double-blind study, and you try to see if an intervention worked, 30% of the benefit of any intervention is considered the placebo effect. So anything over 30% is attributed to the procedure. Once again, 30%. If they ask you how many patients die and have a pulmonary embolism during autopsy, what would be the percentage that you would probably hear? Correct, 30%. So if I ask you how many hospitalizations are probably attributed to adverse reactions to therapy, what would you say? 30%. We're working on this. So before you order any questions, any lab test, your goal is to say, are these results going to affect your treatment? If you think somebody has a sinusitis and they've had it for 10 days and they're worse after 10 days than they were in the first 4 days, and you think they need an antibiotic, do you need a CT or MRI of their sinuses? Yes or no? Correct. necessary. You probably don't, because it's not going to change the way you treat them. Okay? If you have a patient that has HIV who comes in your office and you're trying to determine when to start antiviral therapy and one type, and you have to know the viral load, does it benefit you to initiate testing before you start treatment? Yes, of course. If somebody comes in and they say, I've had a backache and I've had it for 3 days and I have trouble getting out of the bed, and I took an ibuprofen and it really helped, but I just want you to tell me if this is going to continue. Do you need an x-ray of the back? And the answer is no. And you'll find when you're working up all these patients, somebody has already given you guidelines or rules of when to do tests, x-rays, MRI, CAT scans, when you're dealing with an acute patient and a chronic patient. So when you order a test, you have to know, what will you do if the results are positive? What will you do if the results are negative? Is the answer same for both? You probably shouldn't do the test. If the answer is different, you should. So when you're learning about when to order tests, sometimes you may ask your preceptor, and they may be able to give you the reason that they're ordering the test. Now, why do you think people order tests in a healthcare setting? What would be a reason? Remember that money drives our practice. Diagnose illness, diagnosis, differential diagnosis. Sometimes it's merely to have the person come back in the office. We have to be honest about that. When you have people that you put on a lipid-lowering therapy, and then you follow up with that in, 3 months, and then again in 6 months or in 12 months, then you have them come back to discuss the results of the test. So sometimes when we order tests, we are only ordering the test so people come back, and if they come back, we can charge for that. Please be aware of that. Why I'm telling you that is sometimes when you talk to your preceptors, that might be actually the reason, and they may not want to put words to that. So not everybody can tell you why they did or they didn't order the test. There is a book put out by, I'm missing this lady's name, but she was at University of California. She wrote Novice to Expert, and she wrote The Art of Caring, and her name is, Ellen, do you know who I'm talking about? Benner. Thank you.
Yeah, Benner.
And Benner. And what she talks about is there are 5 stages of learning, and all of you are probably in the novice stage. And when you're a novice, you should probably best be put with a person who has been in the field that you're going to go in for 3 to 5 years, because those people who have been in the field for 3 to 5 years can remember what it's like to be a novice. What is hard to do is to take a novice and put them with an expert, because most experts cannot give words to why they do what they do, because it's automatic. They look at the patient, they ask them 3 questions, they know the diagnosis, they know the treatment, they don't have to order a test, and they're correct. They're expert diagnosticians. They can't give you the words in teaching you how to do it because it's so simple for them. It's like those of you who have raised 2 to 5 children, when you try to explain to a new mother the differences in their cries, you can't do that. You just know the differences in the cries, but you have difficulty explaining it. Other factors to consider when you're ordering tests is, what is the cost? What does the insurance pay? What is the copay? I was talking to a few nurses at the hospital, and they have a new insurance, and they have a $1,500 copay for their family for the year. And so when they go to any healthcare provider, it matters to them what the cost of any procedure is because they have to pay up front until they've met their deductible. And I live in a really small town, and they found even for an MRI and a CAT scan within 6 different locations in this small town, there's a $3,000 difference. So it's important for you to know who in your area does pay for services. Do they give a discount? Do they accept money up front? And what's the variation in the cost? And what's the copay? And then what's the risk benefit to the patient? At some point, you may determine that based on that patient's age, that a workup is not important. I had an 89-year-old come in the hospital 3 weeks ago, and I'm with nephrology, so I was asked to look at them because his creatinine was 2.5, and he was in a thing called acute kidney injury secondary to dehydration. But they were thinking maybe he had pneumonia because his family members said he had been coughing for 2 days. So they did a chest x-ray, and they found a 4-centimeter mass. And they called in the pulmonologist, and the pulmonologist wanted to do a CT non-contrast of the lung, and then he wanted to do a bronch and a biopsy. The second day I went in to see the patient, he was in 4-point restraints because he had dementia, and he had delirium with the dementia based on his change in location and being in the hospital. And now they had him on the novel antipsychotic risperidone. And I talked with the daughter, and I said, you do not have to have this worked up. And she just didn't seem to get that point. She said, yes, we do. We always have to know if it's cancer and what's the benefits and risk of treating it, and what will be his longevity without that knowledge. And so you have to know that. You have to know what is the cost in terms of health care and emotions and working up any disease based on their age or their health care standards. If you have somebody who's a New York classification heart failure patient 4, and they come in and have a chest x-ray and you find a mass, you may not want to work them up. I can't give you my values, but I can say you're going to make values based on age and outcome of the risk benefit of working that up through the ages. And it's not just based on Obamacare. And I'm going to go through the rest of these slides quickly. Test accuracy. You should know the sensitivity and the specificity of most tests. Sensitivity means that if you have a test and you have the disease, you will have a positive test result. Specificity means that if you have the test and you don't have the disease, that you will have a negative test. So when you're ordering tests, you need to know the sensitivity and specificity. You can find that on Google. You can find that in lots of pieces of information, especially, sources of information, Medscape and Hippocrates. And you need to know that some tests are not sensitive, nor are they specific, but they are costly. This is the positive predictive value, and it's talked about when you talk about the gold standard of tests and how those tests are used to determine if a patient really has a disease. So we have a positive predictive value and a negative predictive value. I think sensitivity and specificity is more important than the negative and positive predictive value. What do you think, Ellen?
Yeah, I agree with you.
There's also called, so this is the predictive value just for you to look. And then there's another term that they use called the likelihood ratio, and that's where the sensitivity and the specificity are put together. And the goal is over 10 confirms the diagnosis. Once again, you're going to see that more when you look up tests, whether it's a lab test or a biopsy or a blood test. It's going to give you the sensitivity and the specificity, and your preceptor should know that once again along with your tech. General principle, know the accuracy of the test you're ordering. You always retest borderline results. Recognize that when you do serum, the serum, you're assuming that the serum, the blood in the vein is equivalent, or the values are equivalent to the values in the cell. That's not always true. So when you are trying to determine, an example would be when you're talking about evaluating for hypothyroid, hyperthyroid. Sometimes people, there's a disease called subclinical hypothyroidism. Instead of treating 0.3 to 3, some people will treat 0.25 with symptoms, and they'll start them on a low dose of Synthroid. You have to know with Obamacare and in the future is if you treat somebody who doesn't have a positive or negative lab value to confirm your diagnosis, if insurance will cover it. You need to know what are the patient norms in your facility for age, gender, and ethnicity. For you to know, a hemoglobin A1C has usually been tested on white middle-class Americans. We've found that African-American males, it's usually 1 point higher. When you talk about hemoglobin, usually you can say 12 to 16 is the normal pints of blood, but that is for males. It's not for females. It's not for the elderly. So you need to know what are the specificities in your facility for those three things. You want to compare previous similar labs, and sometimes now in the hospital I work in, they'll actually graph those labs over the last few years so you can see if somebody's going up or down. Sometimes multiple tests are more significant if you see a trend. Sometimes it's more important to order a panel than it is to order a specific test. In our hospital, it's better to order a thyroid panel versus a TSH and a T4. So that is facility dependent. There are variation between labs. I live in Foley, and I also work in Atmore. And in the Atmore Hospital, when I look at saturations of iron to determine if somebody needs Venifer, their norms are 20 to 50, whereas the norms here in Foley are 15 to 30. So you have to know what the norms are in that geographical location. The only test that doesn't have a geographic determination is your INR, which stands for International Normalized Ratio, and that's what that actually means. That it doesn't matter if you're in Japan or Australia or California, they use the same reagent. So INR 2.5 in Alabama or Michigan or California is a 2.5. You also need to know what are the drug interactions between that test, when somebody has a clerical errors, and if you need a CPT code for each test ordered. When I order labs, I have to know if I have to put down anemia of chronic disease or I have to put down CKD stage 5 to substantiate that. Usually to find the CPT codes, usually there's somebody in your office in billing who knows how to do that. I don't do that. The office manager does that. So I don't even know that. Ellen,
on the back of our billing sheets has the most commonly used CPT codes, and what we do is we just check whichever ones that we want.
Right, it's going to be ICD-10 anyway. So informed care, what you want to do is tell the person what you're ordering, why you're ordering it, how they are prepared, what they have to be educated about, and what will the test results be. And so uh, that means that you have to know what actually an MRI encounters. What does a spec test mean? What were the results? When will they get the results? And I don't always know those answers. I know what tests we require, and but I don't know a lot of tests. So when you're ordering tests in your particular facility, this is the time to talk to the medical assistants or the LPNs or who works in the office, because sometimes those are the ones who actually go in the office and talk about the test preparation, the cost, and where they get it, and how long it takes to get the test result. Once again, it's nice to know the sensitivity, specificity, the incidence of that disease entity, and that's where we go with Ockman's razor when you hear hooves, thinks horses. So if you live in a place that has Legionella pneumonia or Moxarilla catarrhalis pneumonia, or they have a urine that's mainly E. coli resistant to Cipro, usually there's a geographical location about what you have in terms of incidence of disease. And the other, it's nice to know if you know a spectrum of disease. There's a difference between a first encounter with an asthma attack and then somebody who's had asthma for 20 years and what their PFTs will result in. So it's nice to know what is the spectrum, what's the beginning of the disease, what's the end of disease. And an example of this, when I have patients in the hospital with pneumonia, so many people think that once they finish their Z-Pak, they will be over the cough and the croup, which they won't. I read one article that says it takes a week for every decade you are old to get over a infectious disease, especially of the lung. Remember that pneumonia is like scraping the inside of the lung with fingernails, and it doesn't all heal in the same way. So when we're ordering tests, especially dealing with pneumonia, and you order a test and you find they have consolidation and you treat it, sometimes you want to take a repeat of the chest x-ray in 8 to 10 weeks if they're 80 years old to see if they have resolution. And you have to tell them that you're going to be sick for a while, and then give them some expectation and why you're ordering the test now or a series of tests. Informed care, what is infection, ethics in the law, margin of error. You're going to learn that from your preceptor. When do you have to write down that you told that person about what the test results were, what the drug was, and how do you validate that? And I don't know in your geographical area what is considered the standard of care for what you do. But sometimes we have to write down that we talk to people about the benefits and risk of the test, whether it's a pregnancy test or an HIV test or a PSA test. And sometimes you don't have to do that. So that's geographically determined. When you get the abnormal results, know the norms and the implications. Is this a serious problem, a moderate problem? What's the availability? What's the follow-up care? How do you document it? And how do you disclose the results of the implications? I'm sorry, renal replacement therapy. Um, so disclosure results and implications. And nowadays with the HIPAA, you have to know if you can leave that information on the phone and who you can give that information to. Can you hear me now, Ellen?
Yes.
Thanks. Routine screening, you have to know in your facility, who do you screen, when do you screen, and what is the standard of care? Do you begin mammographies at age 50 or at age 40? Does your practitioner actually do PSA screening? Do they ask the people to get a colonoscopy? So once again, it's practice dependent and geographically dependent. Now I'd like you all to be as good as this gentleman is in diagnosing, and maybe you will be there. So the value of the diagnostic test, anytime you can use an outside resource, it's nice to know that. The other is I'm a person who really likes algorithms. Sometimes you're going to get an algorithm that says you do this test, and if this comes back positive or negative, you do this, and if it comes back not positive or negative, you do that, and that's always nice. Ellen, do you like algorithms?
I really like them a lot. I use them a lot.
Okay. I do too, and there's so many out there. So here are some tests. Here's a complete blood count, and this is when you want to look at all the white blood cells of your body. You need to know in your hospital, do you want a CBC or a CBC with DIF? What's the difference in the cost? What are you going to do with that information? Now, I'm not going to go over this because I know that you've all had patho, and you should be able to explain what is a leukocyte and what is the goal in evaluating it. You need to know the white blood cells. What are the non-granulocytes? What are the granulocytes? What am I looking for? Does that indicate a viral or a disease? And what is the age of the patient? What is the gender of the patient? And does that matter in terms of how much I get in terms of these answers? In terms of how many lymphocytes do they have? How many bands do they have? Once again, age, gender, and ethnicity. I told you before that 30% is always a good word or a amount to use when somebody asks you, what do you think is going to happen? 30% chance. The other is if somebody says, ask you, any question about when you're evaluating a patient, what are the three most important things that you should know about that patient in terms of disease? You're not wrong to say I need to know their age, gender, and ethnicity, and because that helps me understand their risk factors for the disease. The WBC and clinical implications. Usually the leukocytosis is an increase in only one type of the white blood cell. It occurs in acute infection, and it depends on a couple of different things. If you have WBC of 20,000 in a 17-year-old, that's different than a 20,000 in a 80 years old. It takes longer for an older person to mount a response to an infection. So if they have 20,000, you tend to think it's much more severe in an older person than in a younger person. It also matters what their bone marrow efficiency and reserve is, and if they're on immunosuppression. So anybody who is on prednisone has a harder time mounting a response to an infection than would somebody who's not immunocompromised. These are other causes of leukocytosis, chronic metabolic problems, hemorrhage, blood diseases. Leukopenia is less than 4,000 WBCs. It can be due to viral infection, corticosteroids. cancer, renal failure. So it's important when you look at those white blood cells, are there too many, are there too much, and is there a specific type of white blood cell that you're looking at? These are other causes of leukopenia. So any organ that is involved with the storage or the manufacturing or the breakdown of any of the white blood cells or the white blood cells, if there's a disease in that organ, that can affect the amount of white blood cells. When we talk about the white blood cells, the neutrophils, these are your segs and your polys. What's the goal of the neutrophils in your body? They eat junk and die. And so the more neutrophils you have, the more junk they're eating. Now, we talk about what is the shift to the left or the right. Does anybody know how that got started? It had to do with where the when somebody was counting this in the old days, a person would count by hand how many neutrophils and how many of the different granulocytes were on, and one was on the left side of the paper and one was on the right side of the paper. And so they found out that neutrophils was on the left side of the paper. So when people are talking about any illness, they're talking about, is it bacterial that they treat with an antibiotic, or is it viral? And when they talk about it, shift to the right, it usually is influenced by a virus, and shift to the left is influenced by a bacterial problem. Eosinophils, usually related to allergies. How you test for them is in the blood, or you have people sneeze into wax paper, and that's a good way to determine if they have allergies in their nose. Erythrocytes are the red cells that come from the bone marrow. You need to know if they're elevated, and you look at what's called the retic count, and if they're anemic, meaning their hemoglobin is below 11, and they have an elevated retic count, that means that their bone marrow is responding to their anemia. If their retic count is down, then their bone marrow is not. That obviously gives you another idea that they probably have a more serious illness. Some people, healthcare providers talk. Some of them talk about hematocrit. Sometimes people transfuse over 7. Some people transfuse over 8. It just depends on what facility you're in, who uses a hemoglobin, who uses a hematocrit. You have to know that hemoglobin and hematocrit are related to hydration. If you're dehydrated, you have a higher H&H. And H&H changes over time, not immediately. I know in the emergency room, people come in who have had trauma. They take the H&H then, and then they take it again in an hour or two to see what the drop is. So it is evaluated usually over time. Now, while we're on the red blood cells, I wanted to talk to you about some facilities now only draw in PD tubes. And that's what, less than 2.5 centimeters of blood. Our facility doesn't do that. I read an article in the New Yorker about a lady in California who is trying to make all tests be done through the prick of a finger, and she's trying to create machines to do that. Now, the downside of that is all those people who have the machines and produce those test tubes would like her not to be successful. So when you're a hospital, it's nice to know, especially if you have somebody who's in there long term, if they're taking blood daily in a PD tube or in a regular tube. This is again about reticulocytes and your RBCs. The RBC's indices are the size and the shape of the red blood cell. If it's tiny, micro, think of iron, I for micro, and iron deficiency, which is very common. If it's macro, think B12. So MCV is your mean cell volume. Usually on the FNP exam, they will give you the normal for the MCV and then ask you, they'll give you the patient and then the normal and ask you what kind of anemia you think they have. When we talk about RBC indices, mainly we look at the MCV, and then we look at the RDW, which is the red diameter width. And if the width is outside the range, that means that you have small red blood cells and large red blood cells. And that means not a good thing, because red blood cells are usually the same size as the cell. So when they run, the vessel, the vein, so that when they run through the vein, especially the arterioles in the lungs, that oxygen will go off both sides of the red blood cell. CO2 will go off both sides of the red blood cell, and then oxygen will be attached to the red blood cell in the lungs. And then when they go to the tissue, the oxygen will go off quickly because there's no space between the edge of the red blood cell and the vascular lining. So if you have a tiny red blood cell, the O2 and the CO2, it takes them longer to pass to the cell, and so you have some kind of anemia or decreased blood flow to the area. So the red DW can tell you the length of time that somebody's had anemia. It takes a while for those red blood cells to change in size. Peripheral smear, these are different types of cells. You'll see that if you work with a hematologist or you're looking at people who have bone marrow dysplasia, and these are usually the elderly who are more apt to have some type of leukemia. And when you look at leukemia, I think there's spikes through the ages when men are more apt to have AML and CML and AML. So it's important to look at the size and the shape of those red blood cells, and they let you know what is the cause of the illness. Other studies, you want to know what the total iron binding, what's the serum iron, the ferritin, the transferrin. It helps you to classify the anemia. Sometimes it's important to know if they have a low anemia and low saturation. You have to give them Benefir before you give them Procrit or Epigen. So this is just helps you understand what is the source of the anemia and how best to treat it. Coagulation studies, we don't do this very often. The bleeding time is usually 2 to 10 minutes. For those of you who shave, you know if you cut yourself and you put pressure on it and then you peek at it in a minute, it's still bleeding, and then you wait 2 minutes and you peek at it, it's still bleeding. That's because the average time it takes to quit bleeding is 2 to 10 minutes. This matters more in some surgeries than usually. We need to know about platelet counts. This is very important, especially if you're using Lovenox. There's HIT, isn't it called HIT-US? And this is when the platelets start to drop in response to Lovenox, and so you have to look at your platelet counts. Remember, platelets are not a cell. It's just a little piece of, it's like cellular debris, and when it gets together in that intrinsic or extrinsic clotting, then it becomes a blood clot, which is very important. Usually during the day, we tear veins and arteries and all kinds of parts of our body every day. So we're always bleeding and repairing during the day, and you need lots of platelets to do that. These are the most often chemistries. This is what a chemistry panel looks like, and depends on your facility if they do a Chem 7 or a BMP or a Chem 12 or a Chem 14. It has to do with the machine that's available in that facility. These are the different types of proteins, electrolytes, glucose, calcium. You need to know, not for the test, but you need to know for each individual what is considered a high value, what is considered a low value. Once again, it's very important to know trends in those patients. Albumin, I think albumin is 2 weeks old, and a pre-albumin is like 2 to 3 days. Is that right, Alan?
Yes, because prealbumin is a better indicator.
Right, but I think prealbumin is like, so when you have somebody in an intensive care unit, there's a thing called an Apache score that's based on if you think that person's going to walk out of that intensive care, and one of them has to do with their albumin level. Remember, albumin is the most important part of the pressure gradients in the body. Remember when you were in undergraduate school and they told you about that thing called third spacing, and you kept saying, where is that third space? Because I understand where the vascular components are, and I understand where the cell is, what's in between them, and that's called the third space. And what is responsible for keeping the water in your body is about 75% water. The water in your cell and not in your vascular space is protein, based on the size and the shape of the protein. So people who have low protein usually have ascites, and they have fluid shifts. And so you see that a lot. So it's nice to know the albumin or the prealbumin. I'm trying to get the next slide. Thank you for your attention. I'm going to get faster. Lipids, it's important to know we think that lipids are somehow associated with cardiovascular disease, which is the leading killer of women in the United States, breast cancer being the 8th cause. How I look at that is I don't look at total cholesterol or triglycerides. It's unclear from the review of the literature how they're integrated in determining your risk factor for cardiac disease. But I do look at the HDL and the LDL and how I explain this to the patient. HDL is happy, high, healthy. The more the better. The goal is 50. LDL is loudly loose and low. The lower the better. If you have one risk factor for cardiac disease, it's below 100. If you have two risk factors, it's below 70. How often you measure those? Usually if you give a medication, you have a response in 3 months. You probably can do it annually and get away with that. Your statin is not as beneficial as diet and exercise. So I'm just going to ask you, what percent change can you have in your LDL with diet and exercise? Excellent, Sarah, 30%. And yes, that's the answer. C-reactive protein, they're using that sometimes now, and they're trying to say, is that a better on a panel for finding out if somebody in acute care syndrome is having a STEMI or a non-STEMI? So they're saying, is that more predictive? Than the troponin, but it's a costly information. It doesn't have a high sensitivity or specificity, but some people are just using it in that fishing approach on a panel. Ellen, do you use that much in your practice?
The high density lipo CRPs, I don't
No,
do
C-reactive,
the,
the C-reactive protein.
yeah, but it's the high sensitivity one that we use for the lipids. We don't use just the regular CRP.
Okay. And so thank you, Ellen. I didn't know there were two different kinds. A lot of times when somebody comes in sepsis, they try to find out if there's they use that in the panel. Diabetes screening, you want to know what's the difference between random and fasting glucose. I think the goal is below 100. The older you get, the longer you've had diabetes, the more lenient we are in blood glucose levels. An 80-year-old who's been diabetic for 40 years needs a blood sugar of 160. Remember that our brain is ruled by thiamine, glucose, and oxygen, so your brain always needs oxygen to work. The hemoglobin A1C is now used as for diagnosing diabetes. Please be aware that there's a difference in a normal hemoglobin A1C for African American than there is for females. For white, what do we call ourselves? Caucasian people, and there are some medications that interfere with the hemoglobin A1C. Liver function test. It's used to monitor statins and your tuberculosis drugs and your oral antifungals. It's also important if somebody comes in with abdominal pain for you to rule out pancreatitis and for chronic problem cirrhosis. So you need to know about your ALT and your AST. Those are the ones you use more often. So if you can just get those two down, SGOT, SGPT, or ALT, AST, and what that means when they're elevated. GGT is used when people are trying to find if somebody is a drinker. If you have somebody who comes in and they have an elevated MCV and they have thrombocytosis, they have elevated platelets, and you think that some of their problems are related to drinking, you can do a GGT, and that can help you determine if this is a liver problem or an alcohol problem. It's not used very often. We usually mainly use the AST or the ALT. Bilirubin, you can use that with liver problems as well as cirrhosis. It can help you determine the source of bleeding sometimes. We're just about there at the end. Renal function test is your BUN and creatinine. The normal creatinine is 0.7 to 1.3, but interpretation is based on what three criteria of the humans is the serum creatinine based on. And the answer would be age, gender, and ethnicity. So creatinine of 1.3 and an 18-year-old who's 240 pounds is different than an 80-year-old female who is 97 pounds. But when we're evaluating the BUN and creatinine, you're trying to determine if somebody comes in and they have what's called acute kidney injury, and that is when the creatinine has gone up 0.5 in about 1 to 3 days. There's a criteria called the rifle criteria to determine the severity of acute kidney injury, but we don't use it very often. But anybody who has an elevated renal function test, you're concerned about what is the source? Is it an acute problem? Is it a chronic problem? Because based on your creatinine, you can use you may have to avoid a CT with contrast and certain medications, i.e. vancomycin, Bactrim, allopurinol, and metformin. So it's nice to know what their kidney function is. So when you interpret the BUN and creatinine, many labs now will tell you based on the patient's age what their GFR is. What does GFR stand for? Kidney function. If you have a GFR of 30, you have 30% left of your kidney function. So when you're interpreting the BUN creatinine ratio, you're trying to determine if it's pre-renal, intrarenal, which would be acute tubular necrosis, or post-renal, which would be bladder obstruction. So I have an 80-year-old male who comes into the hospital and he just doesn't feel good, and they do a BMP, and his BUN is 42 and his creatinine, let's say his BUN is 50 and his creatinine is 2, what kind of cause would I think that is the cause of his feeling bad and his change in kidney function? No, Sarah, it's not dehydration. It is, in this 80-year-old man, it's urinary obstruction. It's an enlarged prostate. Oh, I see what you're saying. It's probably 15 to 20. I'm so sorry. I didn't mean to fool you that way. Pre-dehydration, you can kind of know even without looking at the BUN and creatinine because they have low blood pressure. They're on a diuretic. They have dry mucous membranes. It's the post-renal that you have problems determining. So with people, especially males who are older, you always think that you always do a renal ultrasound or a bladder scan to determine if they have an enlarged prostate and they're having trouble eliminating urine. This is my little your pearl of practice. It's the P's of kidney function. When we think of the BUN and creatinine as the only evaluation of kidney function, the other P's are pints of blood. People who are anemic, the kidneys put out a hormone to the bone marrow to produce blood. So people who have chronic kidney disease usually have less pints of blood, meaning they have a hemoglobin below 11. They have changes in their phosphorus. They can't regulate phosphorus, so they usually have too much. They have trouble regulating their potassium, so they usually have elevated potassium. They have trouble regulating their parathyroid gland, which is the vitamin D3, and we check intact PDH, and they usually have protein in the urine, and the goal is not to have protein in the urine. So that's your pearls of practice, the P's of kidney function. The kidneys produce P, they don't eliminate P, and so we always look at the P's of the kidneys. Pancreatic, we look at amylase and lipase. You look at the relationship. And this is the sensitivity and specificity, and you are trying to rule out pancreatic or liver disease for somebody who comes in with acute abdomen. So I'm going to ask you, because you are doing so good, what is the chance an acute pancreatic patient would have another incidence of pancreatitis? Oh, gosh, you girls are doing great. You people are wonderful. Thyroid function test, we look at the TSH and the T4. The goal is to have the TSH below 0.3 to 3. It takes, once you start a thyroid supplement or you change the thyroid, it changes in 6 to 8 weeks. And so you would do the level, and then they would come into your office and you could charge them for that. You want to take it at the same time daily on an empty stomach. That's either 2 hours before meals or 2 hours after meals. And the question is it beneficial to rescreen everybody above 50, especially females, because that's the gender that's more likely to get thyroid diseases, and the number needed to treat was too large, so they decided that usually we don't screen for thyroid disorders unless the person is symptomatic. Other hormone studies that we do is testosterone, and if you watch the Golf Channel, which I have the opportunity to do every Sunday in this house, you think that every male has low testosterone. I heard a talk on it. We really haven't defined what low testosterone is, but the drug companies would like you to think that everybody has that. There is a problem with testosterone supplementation. They have an increased chance of cancer and heart attacks, but I don't know if that's real or if that's just what I'm reading in Journal Watch. I don't have an answer to evaluating testosterone. It is a hormone, meaning that it has a circadian rhythm, and it's difficult to predict based on age, gender, and ethnicity. They don't have the lab values down. There's also prolactin and FSH. We have several nurse practitioners here who talk about they put pellets in the females and they look at estrogen and progesterone activity or lack of activity, but I don't know much about that. HCG is pregnancy. If somebody comes in your ED, your emergency department, or your office, and you're going to do an X-ray or any kind of test with them that has radiation, or you're going to give them any type of antibiotic, you have to first verify that they're not pregnant. So what is the age of a pregnant, a potentially pregnant female? I would think 9 to 60, by the way. I think 12 is way too old. The average start of sexual activity is 10, by the way. After the start of menses, you don't have to have menses, remember, to be fertile. Remember, if you have polycystic ovary disease, you're not going to have a menses and you can still be fertile. So you have to know, and no, it's not 12 to 65. What's the average age of menopause in the United States? 52. So urine studies, we look for glucose, we look for protein. You can have trace protein in your early AM, first voiding, and that would be okay, and it can be related to exercise. You have to know that you shouldn't have blood. There's microhematuria and macrohematuria. Micro means it comes up, I think it's less than 3 to 5 RBCs on your dipstick or your urinalysis, and macrohematuria is the person having the urine can tell you it looks red. Some people have microhematuria. It's chronic, but it's not related to either a bladder problem or a kidney problem, but it has to be worked. Blood in the urine always has to be worked up. Urinalysis, ketones, if you're on what's that diet called that people were on that they wanted to have ketonuria?
Wasn't that the Atkins diet?
Excellent, the Atkins diet. They told you if you were in if you had ketones in your urine, you were burning fat. I don't know if that's true. When you talk about urine analysis, you want to find out if they have a UTI, and it's usually 2 out of 3 criteria, 0 to 5 WBCs, positive nitrite or positive leukocyte esterase. But many times nowadays, especially in every country but the United States, if we think it's a UTI, it is a UTI and we treat them for it. You don't always have to have a UA to validate that. I think we have the fungal medications over the counter. I think that people should have Bactrim over the counter to treat a UTI. I think it's expensive to get into a provider to have the UA, which is usually $30 to $75, and for them to just start the antibiotic when they think they have it. When we talk about urine for microalbumin, microalbumin doesn't mean just little tiny albumin. It means little amount, usually less than 30 milligrams. You want to know if your diabetic has that because then you put them on an ACE, and an ACE is supposed to delay 5 to 10 years over the amount of protein they have in their urine. So you always test for microalbuminemia in your diabetic patients. Fecal studies, we have patients who have been on antibiotics and then we're checking for C. diff. We guaiac the stools. Usually it's 1 out of 3 is considered positive. We culture it. Now, are you familiar with that, people who have C. diff? What's the treatment with the feces for C. diff? Isn't that called fecal transplantation? Yeah, fecal implant. You ask one of the relatives to donate their feces, and there's GI doctors. They do it frequently here for C. diff. I'm not a part of that intervention. Yeah, it does work. Microbiology, you have to know how to collect it and what's the difference. Why do you want a urine culture? Why do you want a wound culture? And how do you test for STDs? When you come back with a culture and sensitivity, you have to know which antibiotic is best and what dose. Remember when I asked you about the BUN and creatinine? You have to know what the stage of kidney function is before you give Cipro, which is given very often, whether you're going to give it 500 twice a day or 250 twice a day. And in our area, you know that Cipro is free at Publix. So I don't electronically give that medication. I give them a hand script and they take it and get their free. And so you need to know in your community what are the $4 drugs at any of your drugstores and which of your drugstores give free antibiotics. Viral studies, if somebody comes in and you think they have oral or genital herpes, you can do a tack smear. But if it looks like herpes, it acts like herpes, and the person says they're burning, and this is not their first episode, and they can tell you what it looks like, you don't really have to culture it. We do culture for hepatitis B, all the hepatitis, HIV, and the whole panel of hepatitis. Now I work in, what do I work in? Nephrology, and they actually have to evaluate for hepatitis in B and C for every 90 days when you're on dialysis. I think in the age of, in the 80s, didn't they start giving all infants hepatitis A and hepatitis B vaccines, Ellen? Or does anybody know that?
They did the hepatitis B, but not in our area. They didn't do the hepatitis A in our area, just the hep B.
Okay. In Georgia, 90s for hep B. In Georgia, they did the hepatitis A and B on infants. Cytology, PAP may be replaced by HPV DNA testing. The criteria for having a PAP, if you haven't changed partners and you have a negative PAP for 3 years, you can probably go for 5 years. If you've had a hysterectomy, you don't need a PAP smear. So it's questionable who needs that, especially if you've never had positive HPV DNA testing, if you really need a PAP. Screening guidelines, it's usually based on the number needed to treat. If you have to treat 15 people at the cost of so-and-so to prevent 1 death, and you'll see that in all the studies. And that's done in the mammography studies, and that's why it came out that starting at the age of 50 to do the mammography on the number needed to treat. And that's done for all of those. And I just put that down. Remember, money drives the healthcare budget. And I think our healthcare budget is what, 19% of the overall budget. We're we have anyway. That's what we are. We spend a large amount of our dollars on healthcare, but we don't have good healthcare in America. Radiology, it's important for you to know the difference between an X-ray, a CT scan with and without contrast, an MRI, an ultrasound, Doppler, PET, SPEC, FNA, and a biopsy. What does it cost in your area? Who does it? Because you are the captain of the ship, you have to know that all those tests are operator dependent, and they're also dependent on the skill of the person who reads that. So it's important for you to know who reads it. Now, I work in a small hospital, and if I read an X-ray that says follow-up recommendation, I can call that radiologist and speak to him and say, is there anything particular I can look for? If in your FNP program you ever have the chance to spend 2 days with a radiologist sitting in that dark tomb, reading chest X-rays, CT scans, it's so worth your while to learn in an X-ray what's the difference between bone and soft tissue. Why would you do a CT scan? Why would you do an MRI, a PET, a SPEC? Can you do it in the hospital? Can you do it out of the hospital? Does it aid in your diagnosis? Does it not aid in your diagnosis? PET and SPEC are mainly done for cancer diagnosis. Words of wisdom: when you're ordering a test, know lots about the sensitivity, the specificity, the cost, and whether insurance cover it. Document the results of those tests. Follow up with the patient regarding the test results. Know if you have to do that in writing or if they can access your site by the computer to follow up on their own test results. Always repeat abnormals. If you have a test result that is not what you expected and it doesn't seem right, please repeat the test before you treat. Know how to interpret the test results before you order it. Before I ordered D3, the vitamin D workup now that they now ask for, the D3 and the D2, it's important to know what are the standards. Do you treat below 20 and why do you treat? So of all the things I've said tonight, this is probably the most important slide because it kind of goes over a few of the things that I'm going to ask for on the test. And so you can look at this again. And so let's celebrate the end of the first WIMBA. I'm tired. You're tired. You've been very attentive. It's been an hour and a half. Any questions? Yes, Lisa. Yes, they do overread your X-rays. Some people overread it. Some people underread it. It's nice to know if you're working in a hospital. Usually the hospitalist or some of the people know when they see a name that that person overreads or underreads. It's important to know on X-rays that X-rays don't actually, especially chest X-rays for pneumonia, don't tell you what that patient is today. X-rays, it takes maybe 24 to 48 hours to catch up with signs and symptoms of the patient. A dehydrated chest X-ray is not going to show you pneumonia. An overhydrated patient will show you a lot of curly B lines, but it may not be congestive heart failure. So you really have to know your radiologist, know your patients. You have to know in your facility, is it better to do a PA and lateral in the facility, and I mean to do that down in X-ray, or to do it in the room, and what's the difference in the cost? What is a wet read? A wet read is if you have a patient sitting in the emergency room, and you have to know, because there is a guideline, if somebody comes in and you think you have pneumonia, you have to treat them in so many hours. And you have to document that. So you want a wet read. You want them to read it as soon as they've done and call you in the emergency room with the results. And the other thing with an x-ray is many times if it's a wet read, then that's the reading by the radiologist. Now, and you'll learn this about when you code for in hospital and out of hospital, whether you code a 1, 2, 3, 4, and 5, if you interpret that x-ray or that EKG or that CAT scan on your own, you can, that's worth 1 point, and you can upgrade a visit from a 3 to 4. So it's important for you to be able to look at an EKG, to look at an x-ray. A CAT scan is just spaghetti to me. If you have specific questions, I can give you about 5 minutes. You can type them or ask them. It's not chapters, Paul, for the test. It's this particular presentation, cancer screening and diagnostics. So thank you for your attention. I archived this. 12 questions, yes. I only want, Charlene, one ICD code because you have to get to know them. And once again, as Ellen said, they're on the back of her billing sheet. They're on my billing sheet as well. So you should probably have a billing sheet in your office, or talk to the billing or the office manager, and they can give that to you. Paul, there is no set amount of patients you have to see. There's just a set amount of hours. If you can document on all your patients, fine. If you see 5 patients for sinusitis and you just want to group those together, to do that. You know, you can use an ICD or a CPT code. You're learning. Just learning the codes is important. Any other questions? Oh, thank you. And of course, you all leave this class with 30% in age, gender, and ethnicity. Thank you for your attention.